Okay, so this is a brief presentation just on the genetics of cystic fibrosis. Genetic cystic fibrosis is a common disorder. 1 in 3,500 Caucasians have cystic fibrosis. The carrier frequency is about 1 in 25. So if you put 25 people in a room, one of them is a carrier for one non-functional copy of the CF gene, although you need 2 non-functional copies before you present with any kind of symptoms. In contrast, in the Asian American population, the frequency of cystic fibrosis is 1 in 3,100. It's actually believed by a lot of population geneticists, why is cystic fibrosis so common in the Caucasian population? People believe that having one non-functional copy of this gene, which we're going to go over in a few minutes, the CFTR gene, decreases the chloride transport, therefore decreases the risk that people would die of things like cholera in the Middle Ages. And if you don't die, you pass your genes on to the next next generation. So it might have had some type of selective advantage. That's not important information for your boards, but it's just kind of, why would a gene be so common in a certain population, similar to sickle cell that people hypothesize, although there's a lot more evidence about malaria. So cystic fibrosis is inherited in an autosomal recessive fashion. If a couple has a child with CF, there's a 25% recurrence risk. But again, look at people don't know what they're a carrier of, although we're starting to understand a little bit better because now a lot of people have carrier screening before they have babies, but we all carry about 6 to 8 genes that don't work right. And you only have an affected child if you both carry the same gene that doesn't work right. So you can look at this whole 3-generation pedigree and nobody else had cystic fibrosis, but these 2 individuals married each other and they had 4 children. One is not a carrier, inherited both normal alleles. This child inherited an abnormal allele from one parent and normal from the other. This child inherited abnormal for one, normal from the other, and this child inherited both parents of the non-functional copy of the gene. So unlike sickle cell anemia, that's pretty straightforward, there are over 1,300 different changes in the CF or CFTR gene, which can result in cystic fibrosis. 1,300. And any combination can result in CF, although some might be milder than others. Of these 1,300, though, delta F508 is the most common. And I just want to go over what the delta F508 is. So here's the normal sequence of the CFTR gene. ATC, ATC, TTT, GGT, GTT, isoleucine, isoleucine, phenylalanine. This is phenylalanine right here, this triplet, and then we get glycine and valine. At the 508th position, 3 base pairs come out. So it goes from ATC to AT. Instead of ATC, it's ATT. But hey, look, it puts in the same amino acid, and then TGG, this TT, GGT, GTT. So you end up with isoleucine, isoleucine, glycine, and valine, but you're missing this phenylalanine in the middle. So this is the most common gene mutation. At least one copy of this delta F508 mutation is identified in 70% of patients with CF. Again, there's over 1,300 different changes, but 70% of patients that have CF have at least one that's a delta F508. So we talked a little bit about the ASO, which is a PCR method, an inexpensive method to do carrier screening and use common mutations. And again, since 70% of patients with cystic fibrosis have this change, this is actually one of the methods we use. We actually, in Illinois and many other states, again, they're not going to ask you on the board, and I'm not going to ask you on the exam about newborn screening, but patients with, it's an inexpensive method to kind of combine PCR and amplification to determine who might be affected or a carrier for common mutations. And since delta F508 is the most common, we have primers for both normal sequence of DNA and the delta F508 sequence of DNA. So we make primers for each. And if the if the individual has normal sequence and all they have is normal sequence, then all you're going to see is amplification from the normal sequence. If they have a delta F508, then they're going to have amplification from the delta F508. And if both copies are delta F508, then you're not going to see any normal DNA. Whereas if they're carriers, we're going to see both. We're going to see amplification from normal CF, or the normal CFTR gene, and the delta F508. Now, if they have a different mutation, then you just wouldn't see the amplification. But it is a good method, an inexpensive method to look for common mutations. So the gene responsible for cystic fibrosis is located on the long arm of chromosome 7, and it codes for a chloride channel that sits in the cell membrane. The problems associated with not transporting chloride correctly is because of viscous mucus, and it results in respiratory issues. That thick viscous mucus there's a lot of infections in the lungs because of the secretions. In the GI tract, this is actually really important. Meconium ileus, which is when the initial stool in the baby it gets stuck in there and causes an inflammatory reaction, and ileus occurs in 15 to 20% of affected infants with cystic fibrosis. And in fact, the flip side of that is if we have a baby with a meconium ileus, about 75% of them actually have cystic fibrosis. And this also, in addition to the meconium ileus, other GI issues associated with cystic fibrosis include malabsorption resulting in failure to thrive. And that's actually the reason that we do this on the newborn screen. Because of this viscous mucus, there's also a risk of pancreatic insufficiency. And bilateral absence of the vas deferens results in infertility in the vast majority of males. And as I was saying, the delta F508 is the most common mutation, but some males actually don't have significant cardiac disease. And the only symptom is infertility. Sorry about that ambulance, the problem with living near a hospital. So CFTR, when the chloride channel does not work correctly, the chloride ions don't move in and out of the cell. And one of the things, if the chloride's not, the sodium follows the chloride. And so babies with cystic fibrosis were thought of salty babies. Like this was an old wives' tale that the grandma would taste the baby, and if it felt salty, tasted salty, they would think of it as cystic fibrosis. So here, here's an example. Here's just a diagram. This is here's the normal transport of the chloride, and when the CFTR channel is not working correctly, it doesn't let the chloride pass. Now, there are a lot of different changes in the gene, like I said, over 1,300. And one is that there is, so normally we make our CFTR protein. It goes into the ribosomes. When the ribosomes make the protein, we make our RNA, it goes to the ribosomes to make protein. The protein gets into the Golgi, and the Golgi brings the chloride channels up to where it needs to be in the cell membrane, and it transports chloride very nicely. But what if we have a nonsense mutation? A nonsense mutation means there's a premature stop codon, and so it actually makes our RNA, but the RNA doesn't make any protein. It doesn't get into the Golgi, and we get nothing in the cell membrane. Next, I want to talk about missense mutations. So missense mutations, you're making a protein, but there's something wrong with it, and it never actually, there's a lot of things that can go wrong. One is we make the RNA gets to the ribosomes, it makes a protein, but the Golgi's like, I can't fold you, you're a piece of garbage, I am not bringing you up to the cell membrane, you're useless, and it discards it. The second is there's a change in the gene that the RNA gets to the ribosomes make a protein, the protein makes a cell membrane, brings it up to the cell membrane, it folds enough, but it doesn't actually transport chloride. Or it transports chloride, but not well enough. Or we have less protein, or sometimes it's less stable and it doesn't stay there as long. All of these, this isn't as severe as obviously this, but these are all different changes. But you might notice the delta F508 is in this no traffic, and this is known as a gating defect or a trafficking defect. So this is the delta F508 is a trafficking defect, and all of these are gating defects, that they're not transporting the chloride correctly. So personalized medical management, there are medications now being developed to address the specific problems, and I'm going to leave that to Dr. Broderick to go over those medications. So if, for instance, there's a splicing defect, no protein is made, that might help the DNA like splice past where the premature stop codon is to make some kind of protein. It might not be completely normal, but it will help. And then the trafficking defects, if there's an abnormal protein, this is actually a medication that can get into the Golgi and shove, that, protein that we made into the right structure, so it'll make it up to the cell membrane. And finally, gating defects, if the chloride channel, we get the protein into the cell membrane, but it's not transporting chloride, these will help with this. And again, the specifics of those medications I'm leaving for Dr. Broderick, because he's better than me with that. Disease is associated with mutations of the CFTR. Again, cystic fibrosis. The other is bilateral absence of the vas deferens. Again, a man comes in, him and his wife have been trying to get pregnant for a long time, and they have been unsuccessful, and we find out that he has 2 changes of the CFTR gene. He may not have respiratory issues, although it's funny when we really start talking to people, they have symptoms, but they aren't as severe. Or hereditary pancreatitis. This is people that have recurrent pancreatitis having a CFTR gene mutation. And again, maybe one of them isn't the delta F508, because that's more the classic, might result in this. So the delta F508 mutation in CF is defined as a truncating mutation, a splice site, a narrow channel mutation, or a post-translational defect in folding of the protein. And this is a folding problem. This is a folding defect, okay? And that's really the only one, nobody's going to ask you any other mutation, but as long as you know what the CFTR, that this is a folding trafficking defect, that's all you need to know. So it's a trafficking defect or a folding defect. I actually took this from an actual USMLE question. So this particular gene change is known as a trafficking defect because you're not able to fold the protein correctly in the Golgi. And that concludes this lecture.